Just give introduction, then we'll start.
Yes, sir.
Dear members of White Army, welcome you all for the surgery comprehensive clinical class. Today we are really blessed to have legend himself, the authority in surgery himself. Yes, who doesn't know about Professor Shenoy sir? He needs no introduction among medical students. Still, it's a great privilege and blessing for the White Army to host him once again after a long time. See, he was last few months. I have been constantly requesting him to guide our students, members, but he was busy with his own. As you all know, he has written multiple books, and recently he has also published his recent edition as per the CBME guidelines. So all of us, including me, have passed our surgery UG exams because of his book, very valuable book, Manipal Manual of Surgery. Also, after that, he also released the clinical books and many other books. So soon it will be made available for all our White Army members at a very discounted price. So I am directly discussing with the publishers. So that valuable book should be made available for all. That's our concern. So we passed. Let all our juniors also should pass easily with the help of those valuable books. So we are
Thank you. Thank you. Thank you, Kishan, for your kind words.
Welcome to you.
Yeah.
And as a presenter, I don't know what to say, Mr. Aakash or Dr. Aakash, because just now, dear members, it's a memorable moment because just half an hour back, his results have been announced, and he has qualified the final year of MBBS with distinction in surgery, medicine, and OBG. And he's become a doctor now officially. So he's welcome to you, Dr. Aakash Kumar. What a moment to celebrate your this doctorhood in front of the legend himself, Rajgopal Shenoy sir, and in such a big platform of the White Army. And
Yes,
I really appreciate your interest. Even after finishing the exams, you are keenly volunteering to present so many surgery or other medicine clinical cases to help your juniors and others. Really appreciate it. Okay, once again, welcome to you, Dr. Aakash.
Thank you so much, sir.
Congratulations.
Thank you so much, sir.
Again. Okay.
I am very grateful to the White Army and you, sir, for letting me present in front of the legend himself. It is a dream come true for me.
Yeah.
Truly a dream come true. Thank you so much, sir. Thank you so much.
So, and also we welcome all our active members. Please make the best use of this opportunity to learn from the best. Okay, this is called Let's Learn from the Legends. So, with the mentor's permission, we can start the session. Over to you, sir.
Yeah. Thank you, Kishan, for the kind words. And I just want to say that competency-based medical education is a new concept brought out by National Medical Commission. So the new edition, 6th edition, I have just released, incorporating the most possible competencies. It's a very vast subject. It covers the theory part, text part, small group teaching, skills, labs, skill laboratory, all that thing. So within the possible limits, we have incorporated most of the changes in the book. Rest, of course, you study in the clinics. Book also has got a lot of clinical material. So just to say whether it's an examination of the breast, thyroid, etc. So that's what is the new format of the book, which includes ethics, communication, very important, biomedical waste disposal, consent, research. So many new aspects have been included under what's called a basic principles of surgery. So these are a few changes which we have brought out, and whatever Dr. Kishan told, we wish that our White Army, all the subscribers will be able to get the book at a discount. Thank you. With this, I think Aakash, you can probably go ahead with your presentation.
Yes, sir. Sir, is my slide visible, sir?
Yes, it is visible.
Can you make
With
it
your
full,
permission?
please?
Yes, sir. Shall I start, sir?
Please.
Yeah, please go ahead with the start.
Yes. A gentleman aged 69 years who works as a primary school teacher of lower middle socio-economic class came with the chief complaints of swelling below the left ear lobule for past 10 years. The patient was apparently asymptomatic 10 years ago, following which he noticed a swelling below, behind, and in front of the left ear lobule, which was insidious in onset, gradually progressing in size, initially pea-sized and currently attained the present size. The swelling is not associated with pain. There is no history of fever. There is no history of variation in size of swelling or pain during food intake. There is no history of difficulty in swallowing foods. There is no history of difficulty in opening the mouth. There is no history of ear pain or ear discharge. There is no history of rapid increase in size of the swelling. No history of ulceration of skin over the swelling. No history suggestive of facial nerve involvement. There is no history of loss of weight or loss of appetite. No history of cough with hemoptysis or bone pain. There is no history of dryness of mouth or joint pain. There is no history of swelling on the contralateral side. There is no history of ulcers or swellings over scalp or the neck. Past history: there is no history of similar illness in the past. The patient is a known case of diabetes and hypertension for the past 20 years and is under medication. The patient is not a known case of HIV, tuberculosis, or any head and neck cancer. There is no history of previous surgeries or drug intake. Personal history: the patient consumes a mixed diet. He has a normal sleep-wake cycle. The patient has normal bowel and bladder movements. There is no history of alcohol intake, smoking, or any other addictive habits. The summary of my history: a gentleman of age 69 years came with complaints of swelling in front, below, and behind the left ear lobule for past 10 years, which is painless and progressive from pea-sized swelling to a current size.
Akash,
Yes, sir.
yeah, we'll go to the first slide.
Yes, sir.
Yeah. So now, just one or two things. What is the relevance of knowing the lower middle socio-economic class in your patient, in your case?
Yes, sir. The lower middle socioeconomic class people usually have the tendency of eating pan or alcohol due to stress. So this will cause an enlargement of the parotid or dryness of mouth, which will lead to a parotid enlargement. Sir.
No. Do you think pan and alcohol causes parotid enlargement?
It will
No.
pan chewing will cause dryness of the mouth, sir.
No. I think you should not be under the impression that pan and alcohol causes don't confuse the alcoholic, that parotitis or parotid enlargement in cirrhosis, etc. Okay.
Yes, sir.
So you should not. What's the difference between silosis and sialadenitis?
So silosis is enlargement of the gland, sir.
Yes, without inflammation.
Without inflammation.
Can you give me
And
some examples for the silosis?
Sir, it occurs in chronic alcoholism, sir.
Yes. Any other conditions?
In case of chronic drug intake, sir.
Any other?
Metabolic disorders such as diabetes.
Yes. So I think that is not relevant to what you have written. What answer I wanted was, in your case, especially here, is that the reason why these patients may come little late to the hospital. Is it clear?
Yes, sir.
See, lower middle economic group, that's what is the relevance there. But remember, he's a teacher. Okay.
Yes, sir.
So he has come to you after 10 years, correct?
Yes, sir. Yes, sir.
So the reason here, see, each case is different. In parotid, don't say because of that, that parotid enlargement. No, it should not come here. Okay. And
yes, sir.
Looking at the age 69, what else? That means it has started when he was 59.
Yes, sir.
So with 10-year duration, what do you suspect? Usually benign
Usually,
condition or malignant?
it should be a benign condition,
Benign.
sir.
So the first thing, as soon as you see this patient who is sitting in front of you in the OPD, oh,
Yes, sir.
this is 10 years duration, probably benign. That's how the word
Yes.
will start. Next slide.
Yes.
Next, yeah, okay. So here you have written that 10 years back he noticed. See, if you look back carefully,
Yes, sir.
I'm not sure whether he really told you below, behind, in front of your lobule. That is not required at this stage. Okay.
Okay. Yes,
So
sir.
you can only say that patient noticed a swelling near his eye, near his ear. That's all.
Yes, sir.
Don't create an impression to the examiner that you know already the details, etc., etc. Okay.
Yes, sir.
So you can
Yes,
only say that is like mentioning a thyroid gland enlargement. 25 years back, patient noticed on the side, front, lateral, not required. Okay.
Okay, sir.
So 10 years back, patient noticed the swelling in the region of left ear lobule. Yes, insidious, gradually progressed and to attain the present size. Now you have
Yes,
written
sir.
that not associated with the pain. So what are the
Yes.
painful parotid swellings?
Painful parotid swelling can occur in case of any infections, sir,
Give
like
specific infections.
mumps,
Yes,
parotitis 1.
yes.
And in case of if the patient has a history of HIV, he will have a bilateral parotitis, sir.
In fact,
In case,
in children born to HIV mothers, they have a very high incidence of parotitis. Any other cause for the recurrent parotitis?
so in chronic bedridden patients due to poor oral hygiene, they may have parotitis, sir.
You are talking about mouth hygiene being bad.
Yes, sir.
What important is the post-operative parotitis. Okay.
Yes, sir.
So this is what you should learn during your internship time. Post-operative patient, whatever be the reason, some dehydration, some analgesia, patient is drowsy, not able to clean his oral cavity properly. So hot summer climatic conditions, there's a chance of parotid enlargement. Any other
Yes,
cause
sir.
in a young child, recurrent parotitis, anything else you consider?
So usually in infants, it can be due to a recurrent parotitis of childhood, sir.
Yeah, that I wanted the answer, silectasis. Okay.
Silent. Okay.
Like a bronchiectasis, bronchiectasis,
Yes.
silectasis. So there is a dilatation of the duct and ductules, stasis of secretions, and that
Yes.
causes pain. Now, no history of fever and pain indicates inflammatory, probably not relevant here.
Okay.
What is the relevance of this size of the swelling to the pain, etc., in your patient?
Size of the swelling, if it is due to a salivary calculus, sir.
So what I'm trying to tell is that should come last. Okay.
Okay, sir. Yes, sir.
So examiner will ask you in what swellings stones are more common.
It is common in submandibular salivary glands.
So why it's common in submandibular salivary gland?
So because the gland secretions are mucus and viscous, and it has a non-dependent drainage or anti-gravity drainage, and duct will be anti-gravity drainage, and it has a high content of calcium phosphates.
So that
and there is
that doesn't mean it cannot occur in the parotid, but it's not required at this stage. Okay. Here, what is important is 10 years duration. It has grown to this size. Pain, fever, yes. Now, other than that, there are few more important things you have mentioned here. Ear pain. What's the relationship of parotid swelling to ear pain?
So, if there is an involvement of the auriculotemporal nerve, there may be a referred ear pain in such patients.
So it's possible, that it very close to the neck of the mandible, when such a large tumor may be infiltrating, that is the time. Okay. So what's the relationship of difficulty in swallowing of food?
So if there is the involvement of the deep lobe of the parotid, it will push the tonsils
very good
medially.
Very good. So you think any other symptom that deep lobe patient can complain to you? Probably. If it is there, this swallowing difficulty, snoring.
Yes.
Okay.
Snoring.
Yes. So what I wanted to emphasize here is that relationship to eating and swelling should come later. Okay. Yeah.
Okay.
Next. Now there are big list you have written here. Everything no, like that. See, please
Yes, sir.
remember, rapid increase is definitely accepted. Okay.
Yes, sir.
Ulceration of the skin and all is not required unless
Okay.
patient will show you. It's more of a physical finding. Okay.
Yes, sir.
You could have mentioned that no history of facial nerve involvement, no history of chewing difficulty or drooling of saliva.
Okay, sir.
Let us not become at this stage judge and straight away say no history of facial nerve involvement. Like, okay.
Yes, sir. Yes.
So you should always be specific here. No history of drooling of the saliva or closure of the eyes. That's enough. Two common
Okay.
things. Again here, parotid tumors, loss of appetite, weight loss. This is not a important feature. Okay.
Yes, sir.
Same thing happens in carcinoma of the breast, thyroid. It's not at all. You don't get a carcinoma thyroid patient with loss of appetite and weight loss. Something similar in a parotid also. Okay. So they
Yes,
are
sir.
very significant. No doubt, nobody can tell you are wrong. But what I'm trying to tell you, the priority of that should come last, maybe, or not required at all. And again,
Yes.
what is the most common method of spread of malignant parotid tumors?
Sir, it is a lymphatic spread, sir.
So first, you should always tell is a local spread.
Okay, sir.
So what is the question which you have asked for the local spread? You have written somewhere. I saw that previous slide. I think one no opening of the mouth or something you have written.
Yes, sir. Difficulty in opening the mouth.
So why do you get it?
So it may be due to infiltration of the muscles of mastication or infiltration of the temporomandibular joints, sir.
So what I'm trying to tell is, so local and regional. So lymphatic spread is a more common. If there is a, so even if it is a hematogenous spread, to get cough, yes, fine. But hemoptysis, bone pain, they all, advanced malignancy, anything can happen. So
Yes, sir.
you should not make it as a routine for every case. Examiner, attention gets diverted with too much of this nose there. Okay. So in simple language, even the no history of ulceration of the skin is not required here. Rapid increase, definitely yes.
Yes, sir.
Recent history of pain, definitely yes. Okay.
Okay, sir.
Difficulty in opening the mouth, no history of drooling of the saliva is accepted. Okay.
Yes, sir.
Why joint pain?
To rule out Sjogren's syndrome, sir.
So what you have to tell is not only Sjogren's, say autoimmune disorder.
Autoimmune disease. Yes, sir.
Like it's one parotid enlargement is one of the common problems, salivary gland enlargement. So autoimmune causes. So they may have a fleeting joint pain, fleeting joint pains with salivary gland enlargement. So it is an autoimmune disease. If you put a steroids, etc., it may even reduce. So that is why that important point about joint pain. Definitely swelling on the contralateral side is fine. Why?
So to find out if there is any bilateral tumors like Wadden's tumors.
Good. So again, this ulcer swelling over the scalp, what is the importance?
Over the scalp, it could be a squamous cell carcinoma, sir, which can provide the lymphatics to the cervical lymph nodes, sir.
Not cervical. You can mention about this. You are written about parotid, na?
Yes, sir.
Your title is parotid swelling. I would have appreciated you have written swelling in the parotid region. You understand, no? Slide number 1.
Sir.
Can you go back for the benefit of everyone?
Yes, sir.
Yeah. What I would have appreciated you have written, parotid swelling means your mind is fixed now.
Yes, sir.
You know the case. But in reality, it will not happen. So you should have written swelling in the parotid region. So you can have a parotid lymph nodes there from the scalp malignancy, right?
Okay. Yes, sir.
Any other tumor can spread there? Even eyelid tumors, eyelid tricholemomas. Okay, go ahead. Next. Yeah, it's a past history. why no history of similar illness? See, this is very common mistake done. Carcinoma breast or carcinoma stomach, similar illness. If you think any pre-malignant lesion is there, yes. Otherwise, this is not required to find out similar illness. Recurrent
Okay.
parotitis, yes. Okay.
Yes, sir.
Diabetes, hypertension. Then you are written about HIV, tuberculosis, cancers, all that you are written. Previous surgery may not be relevant in your patient. Yes, go ahead. Anything you want to ask a question at this stage to me?
No, sir. Not
Yeah.
yet.
Mixed diet, sleep, normal, bowel, bladder movements, alcohol, smoking, all that addictive habits you are written there. Yes. Next. So at this juncture, examiner may ask you if this question, what do you think
Yes, sir.
most probable diagnosis?
So it could be a lymph nodal enlargement, sir.
Why do you want to say lymph nodal enlargement? For which lymph nodes will go for 10 years?
No, I mean,
No. Surgery should be very precision,
yes,
surgical.
sir.
No lymph node will go on for 10 years like this. Okay. So
Okay, sir.
just because I said your title should be swelling in the parotid region.
Yes, sir.
After going in for 10 years duration, your diagnosis should be, sir, most probably it's a benign parotid tumor. That's all.
Okay, sir.
That's all. Why? Because it is parotid region, 10 years duration, no symptoms suggestive of malignancy. That's
Yes, sir.
okay.
Yes, sir.
Right? Yes.
Yes, sir.
Go ahead.
General physical examination. The patient is examined in a well-lit room and the consent has been obtained. The patient is conscious and oriented to time, place, and person. Patient is moderately built and nourished. He has a BMI of 21 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals. The patient has a pulse of 74 beats per minute, which is full in volume, no specific character felt in the right radial artery. Blood pressure 100 bar 70 millimeters of mercury in the right upper arm with the patient in supine position. He has a respiratory rate of 14 cycles per minute and he has a temperature of 98.6 degrees Fahrenheit. This is the picture of the.
Can you go back to the general physical examination slide?
Yes, sir.
Yes. Anything you find abnormality or something? Why do you look for pallor?
If there is any associated, if the patient has a history of anemia or something like that.
Then what I want you to understand is, yes, you are started with the low socioeconomic group or something.
Yes,
So
sir.
the anemia means we have a direct bearing for the treatment, correct?
Yes, sir.
So
Yes, sir.
if it is say 8 grams, we do transfuse, but if it is 9, 10, blood transfusion may not be required.
Yes, sir.
So every case, whenever you present, whatever you are
Yes, sir.
pallor, icterus, try to correlate to your case.
Yes,
It may
sir.
not be significant in this patient to examine for all these things. Lymphadenopathy, what you should tell is, I will explain the lymph nodes later. Okay.
Okay, sir.
Because your case is a parotid here. So,
Parotid.
so rest of the part you have examined, no lymphadenopathy. Pedal edema, again, as I mentioned, these are all the general physical examination we should examine, but you should know why you are examining. Okay.
Yes.
Often parotid is a short case. You may not have
Yes.
adequate time. So quickly you should be in a position to come to physical findings. Now,
Okay, sir.
what is looking at the blood pressure, anything abnormal you find, or what is the age of your patient?
Yeah, he is 69 years old, sir.
Do you think 100 is normal?
No, sir.
Something. What is the general expectation for a systolic pressure in a 69 or 70-year-old man usually?
Sir, usually it is the systolic should be about 140 millimeters of mercury.
So anyway, I can't explain that. Whether he's taking any drugs for his hypertension, I do not know. If he's
Yes.
taking, you should please make an inquiry about it. Otherwise, everything is normal. Right. Go ahead.
Yes. So this is the picture of the patient, sir.
Yeah, keep it for a minute so that
Yes.
we can carefully see the location, etc. So just an advice to all who are listening, spend some time always. Surgery cases are not difficult. The careful look itself will give often lots of findings. So yes, please go ahead.
Yes. Local examination. On inspection, a solitary ovoid swelling of size 5 into 7 centimeters, having a smooth surface with well-defined borders, extending from just below the left ear lobule to just below the angle of the left side of mandible. The anterior border is 5 centimeters from the tragus, left tragus, and the posterior border is 2 centimeters from the mastoid process. Skin over the swelling is normal. The swelling raises the left ear lobule, and there is obliteration of the retromandibular groove. The swelling becomes prominent on asking the patient to clench his teeth, and it becomes less prominent on the patient opening his mouth. There are no scars or dilated veins over the swelling. There is no swelling on the opposite side in the left parotid region. On palpation, there is no warmth or tenderness over the swelling. Inspectory findings were confirmed. The swelling is firm in consistency. Skin over the swelling is pinchable. Swelling is mobile. The swelling is freely mobile. Curtain sign is positive. No swelling in the left parotid region. On bimanual palpation, the deep lobe was not palpable. And on bidigital palpation, parotid duct was felt normal. On facial nerve examination, wrinkling of the forehead is present. Closure of the eyelids is intact. The patient has the ability to whistle. There are prominent nasolabial folds. There is no deviation of angle of mouth. Taste in the anterior two-thirds of the tongue is intact. Oral cavity examination. Mouth opening is adequate. There are no nicotine stains over the teeth. Uvula is in midline. Tonsillar fossa is normal. No discharge or blood from the parotid duct. The temporomandibular joint, there is no restricted mobility. On the neck, there is no cervical lymphadenopathy, and there are no other swellings in the neck. On systemic examination, cardiovascular system, S1 and S2 are heard, and there are no murmurs. On respiratory system, normal vesicular breath sounds are heard bilaterally. Central nervous system, there are no focal neurological deficits. Per abdomen, there are no organomegaly. Abdomen is soft and non-tender. Summary: a gentleman of age 69 years with chief complaints of swelling in front, below, and behind the left ear lobule, which was painless, progressive. On examination, it was a solitary ovoid swelling in the left parotid region. It raises the left ear lobule. Left retromandibular groove is obliterated. On palpation, there is no skin fixity. Swelling is superficial to the masseter muscle and deep to deep fascia, and curtain sign is positive, and the swelling is freely mobile. Deep lobe is not felt on bimanual palpation, and the parotid duct is normal on bidigital palpation. There is no facial nerve involvement and no restricted mobility of the temporomandibular joint. Opposite side of the parotid is normal. My provisional diagnosis is a left-sided parotid swelling, most probably mixed parotid tumor with no deep lobe or facial nerve involvement.
Okay, your presentation is good. We'll go back to the inspection, that picture.
Yes, sir.
So, yes. So you are given a good description about the swelling. That next slide. Yeah. You see the swelling carefully, whether you could have made out some kind of a nodularity over the swelling. Go back. Go back. I cannot show that, but yes, one or two, especially middle figure actually. In the center, in the central figure, if you see carefully, in front of the ear lobule there, one big nodule-like thing is there, and also one below. You know, classically they will have a nodular appearance, or even very larger nodules of more than 2 centimeter. They are called as even bossulated surface. It doesn't matter because this is a virtual presentation. No problem. Now come to the next slide.
Yes, sir.
What are the important findings in this slide, which will clinch your diagnosis?
So that it it raises the left ear lobules, and there is obliteration of the retromandibular groove.
1 minute. I will ask you one question. Which parotid swellings need not raise ear lobule, need not present behind the ear lobule?
Uh,
Yes.
Any acute infections of the parotids?
No. Acute infections, you get everything involved. The entire parotid gets enlarged. I have given you a clue. Parotid has got, you know, the extent of parotid, surgical anatomy.
Yes, sir.
So if you think where all the parotid is extending, you will know the answer. Tell me. One question. Does parotid extend to the neck? Neck, below the angle of the mandible?
Yes, sir.
So lower polar parotid tumor.
Lower polar. Warden's tumor can occur.
Not necessarily Warden's. Even a pleomorphic adenoma can occur in the lower part. Not that it cannot occur, but Warden's, yes. So you need not get the ear lobule raised. Okay.
Okay. Yes, sir.
Even sometimes it need not go behind. You heard of accessory lobe?
Yes, sir.
So do you know that part of the parotid is almost in front here, the buccal outer surface of the cheek? So
yes, sir.
Central located, peripheral located. So little bit peripheral located, you may not get the classical signs of what you have got today.
Okay.
Lobule which is raised and a retromandibular groove obliteration. Is it okay?
Yes, yes, sir.
Why does it become more prominent on clenching teeth?
So while clenching the teeth, we are making the masseter contract, sir. Since the swelling is superficial to the masseter, it will become prominent, sir.
That's fine. I think this is one of the important things to know, the plane of the swelling, that
yes,
it is superficial to the masseter and deep to the deep fascia. There you think somewhere you have written about the curtain sign. Why do you get that curtain sign?
So it is because the superficial lamellae of the fascia will get attached to the zygomatic process, sir. So on lifting the swelling upwards, it will not move above the zygomatic process, whereas it will be mobile horizontally, sir. Therefore, curtain sign will be positive.
So keeping that in mind, we don't use the word swelling is freely mobile. Okay.
Okay. Yes, sir.
It's enough if you say swelling is mobile in horizontal direction and vertical direction.
Yes, sir.
Mobility in the vertical direction is limited by zygomatic arch. That's all it is.
Yes.
Okay. So you are not written here. Most importantly is the surface. Surface.
Okay. Yes, sir.
In the inspection wise, you better say approximately measuring about.
Yes, sir.
You understand? You have written there some 5 by 7 or something.
Yes.
So it's always we use the word inspection wise approximately. On the palpation wise, yes, you are supposed to have your measuring tape and measure it so that it's perfect. 5, 7, 8 or whatever it is. And after giving the description about the borders, see, you have written the inspective findings are confirmed. Whether all the borders you felt properly, that is what you should mention.
Okay.
Borders, not only feeling the border, what is the any, they are irregular or any consistency changes, you know, all that has to be mentioned here. Surface is different from the skin. So surface is important, especially smooth surface is seen in which condition? Smooth. Smooth. Which tumor of the parotid will have a smooth surface?
So in case of adenolymphoma.
Yes, that's why it's very smooth.
Yes.
Irregular, very hard irregular. What condition you get?
In mucoepidermoid tumors.
So any malignancy, including pleomorphic adenoma changing into malignancy, or more importantly, mucoepidermoid. And nodular surface. People also use the word lobular, but nodular surface you get in classical pleomorphic adenoma. And more than 10 years, such a large one, I will show you later. You can even
Okay.
use the word bossulated if it is larger nodules of more than 2 centimeter, etc.
Yes.
Instead of using the word by manual palpation, I'll be happy if you say by digital palpation. Okay.
Okay. Yes,
Where is the for the deep lobe? Where do you actually palpate?
So we'll palpate near the tonsillar fossa behind the third molar tooth, sir, upper
That
third
is
molar tooth.
one outside.
Outside behind the angle of the mandible. Sir.
Yes. So outside behind the angle of the mandible. Yes.
Yes.
If you get, you are lucky. So it's not very often felt, but it should be that big enough for you to palpate on both sides.
Yes.
Can you tell me some surface marking for the parotid duct? What is the length of parotid duct?
So the parotid duct is 2 to 3 millimeters in diameter.
I wanted length about 6 to 7 centimeter.
6
That's
is,
fine.
okay.
It actually diameter changes, but 2 to 3 is fine, accepted.
Okay.
Where's the marking?
So it is on the surface marking, it is just below the zygomatic process, sir. And it opens in the vestibule of the mouth opposite to the crown of the upper second molar tooth, sir.
No. What I wanted is from the in front of the tragus, you draw a line to the angle of the mandible. Sorry,
Yes,
angle of the mouth.
Yes.
In the central portion. Okay.
Okay. Yes.
About 2 to 3 centimeter in front. In the middle, that is the surface marking.
Okay.
Of course, there it goes through the masseter, then pierces the buccinator and opens. Yes. So they may ask you this because you have written there, parotid duct was felt. Okay.
Yes. Sir. Okay. Sir.
Any questions from your side at this juncture?
No, sir.
Okay. We'll go ahead for the next slide.
Yes.
Now, yes, it's a. You can mention this immediately because it's a loco-regional examination.
Yes, sir.
Facial nerve examination is one of the most important thing which people should always mention. Case of parotid swelling. So quickly, you should be able to do this test and say that facial nerve is normal. Okay.
Okay. Yes, sir.
Why the taste in the anterior 2/3 of the tongue?
So the anterior 2/3 of the tongue is supplied by the branch of the facial nerve, cauda tympani, which supplies the anterior 2/3 of the tongue via the lingual nerves.
Yes. Next. Before now you go to oral cavity,
Yes, sir.
I have already mentioned to you, loco-regional examination covers the parotid gland. You mentioned about the skin.
Yes,
Then
sir.
comes the facial nerve. Then
Yes, sir.
also you should mention any bony tenderness near the angle of the mandible or mastoid process.
Okay. Sir.
Which malignant tumors can spread to the bones along the longer distance?
Adenoid cystic carcinoma through the perineural spread, it will spread to the bones, sir.
Adenoid cystic carcinoma is a highly malignant tumor. It can spread by perineural spread.
Perineural spread. Yes.
You should examine the parotid and also apart from the facial nerve, and you always look for local mastoid tenderness, especially
Yes.
mastoid region. Once
Okay.
you finish that, then you mention about the oral cavity examination. Okay.
Yes. Yes.
Now, you have only mentioned about the no discharge or blood from the parotid duct. Is it common?
Usually, if there is if it is a malignancy, there will be blood from the parotid duct.
No. You will not get that. Okay. So
Okay.
these tumors don't compare it like a, what can I say, infiltrating duct carcinoma, breast, or with the discharge from the blood, etc. It's a very unusual. It's better to avoid such a controversial thing. Just say parotid duct opening is normal. That's all.
Okay.
Simple.
Yes, sir.
What do you expect if they ask you any discharge? Yes, especially parotitis, recurrent parotitis, pus coming out, concretions, sometimes the
Yes, sir.
inspissated material. that you happen. But usually in a malignancy, we don't get that. Tonsil, uvula, all that you have mentioned. It's a dictum or a principle that whenever you examine one salivary gland, make a practice to mention here about the opening of the submandibular duct also.
Okay, sir.
Where do you look for it?
Sir, on the undersurface of the tongue.
Under surface of the tongue, where? Side of the,
Side of the frenulum, sir.
what's the name of the duct?
Wharton's duct, sir.
So you should mention that, okay?
Okay, sir.
So wherever you see the two openings, this duct and parotid duct, whether the opening is inflamed, means any redness, more than blood discharge, I said about redness. That means
Yes.
some kind of a inflammation is there.
Yes,
Especially in the Warden's duct, stone may be almost, may be visible sometimes. So first discharge. So any discharge is seen or any erythema is seen, that has to be recorded.
Okay,
EM
sir.
joint, yes, very advanced lesions, you may get involvement. Yes, next. What cervical lymph nodes you examined?
So we usually examine the level 1 and level 2 lymph nodes, sir.
Level 1?
Submandibular and submental lymph
Just
nodes.
hold on, just hold on, just hold on.
Yes.
We are talking about parotid, na?
Yes, sir.
Why do you say level 1? Where is level 1?
It's in the submandibular regions.
Parotid goes to submandibular.
No, sir.
Then, so don't confuse now. This
Okay,
is
sir.
not submandibular gland, it's parotid. Is usually what? Lateral neck. Lateral.
Yes.
So posterior, posterior.
Okay.
Behind the sternomastoid. Okay.
Okay,
So
sir.
don't say submandibular node. So you have to say that the sternomastoid is there behind, right? Lateral.
Okay.
Maybe level 2 and level 5 common. Okay.
Okay, sir.
Yes.
Yes, sir.
What will be the nature of the nodes?
Sorry, sir.
If you get a lymph node enlargement in any malignancy, generally we teach you what will be
Yes,
the
sir.
nature of the nodes. What are the important 5 findings you should look for suspected malignant node?
Sir, whether if it is the consistency of the node should be looked
Consistency,
for.
yes. First,
The mobility of the node, sir.
restricted mobility, yes. Third,
the number of nodes involved, sir.
tuberculosis, lymphoma also you get multiple nodes, no?
Yes, sir.
Tuberculosis, lymphoma. Consistency, correct. Irregularity, correct, you mentioned. I think you mentioned restricted mobility. Skin fixation.
Skin fixity. Okay, sir.
You just like you mentioned about the parotid, skin fixation. Anything
Yes.
else? Fungation. These are all the things which you look. And larger nodes may infiltrate even the rupture to the deep fascia and to the subcutaneous plane. Even a platysma gets infiltrated. So it's called a platysma sign, like a
Platysma.
old
Yes,
plat.
sir.
So whenever you have a lymph nodes in the neck, suspicion from the head and neck malignancies, level you make a note of it. And then these are the 5 points out of which 1 or 2 present means you can think, of course, larger nodes also. And not that they are seen in every patient, these findings. So if they are present, they are definitely significant. Okay.
Yes, sir.
No other swellings means?
Sir, if there is any other swelling on the opposite side.
So what you should have written? Better word.
Contralateral side.
No other salivary gland swellings. That's all.
Okay.
Obviously, yes. Then they will ask you, where did you look for? So I look for in the submandibular region, parotid region, and oral cavity also. A lot of ectopic salivary glands you get. What are the sites of ectopic salivary glands?
So in the hard palate.
So you can get anywhere, but common is the hard palate, their lips or even oral cavity, buccal mucosa, etc.
Okay, sir.
No focal neurological, parabdomen, no organ. Yes, right. What's the, we'll proceed now.
Yes, sir.
Yes. Why it's called as mixed? So you are always, when they give you a diagnosis, they will ask you, what is this mixed tumor?
So it is because the most common tumor, benign tumor, is a pleomorphic adenoma, mixed parotid tumor, because it consists of both epithelial and mesenchymal elements such as mucin and cartilage.
That's all the answer. So that's why the word pleomorphism also, pleomorphic mixed parotid tumor. Yes. So that's what it should be your diagnosis. So
Yes, sir.
they will ask you benign or malignant. Answer is
Benign, sir.
benign. If what features were to be present, you could have probably told as malignancy. Remember the 69, 10 years duration, there are definitely chances.
Yes, sir.
Tell me.
If there is any recent onset of pain and there is change in consistency, sir.
More than pain, rapid growth.
Rapid increase in size of the swelling, sir.
Rapid increase is the one important point you should never forget in especially pleomorphic adenomas.
Yes, sir.
So simple question sometimes. Why not? These are parotid group of lymph nodes. You heard of that? Parotid group of lymph nodes. Here, pre-parotid region.
No, sir.
No. We initially we discussed scalp malignancy
sir.
can spread here.
Yes, sir. The pre-parotid lymph. Yes. Sir.
What are the conditions in which you get this nodes enlargement?
If there is any
one is you
hot-
said
no.
scalp metastasis, scalp,
Yes, sir.
etc. Any other condition?
Any Hodgkin's lymphoma, sir?
More than Hodgkin's, it's a non-Hodgkin's lymphoma. Okay.
Non-Hodgkin's. Yes.
So your answer should be usually ear lobule is not raised and they do not go behind the ear lobule. Okay.
Okay. Yes.
And classically nodular surface, right? Classical nodular surface. And forget about this. These are 10 years duration. We don't have any other diagnosis. Only one diagnosis is mixed tumor or pleomorphic adenoma. Why do you say parotid? Quickly, can you summarize and say why do you say it's a parotid gland?
Yes, sir. It raises the left ear lobule. It is present behind, below, and in front of the ear lobule, and it obliterates the retromandibular groove. And on examination, there is a curtain sign is positive, sir.
Okay. Why do you get a deep lobe enlargement, which causes that pushing of the tonsils, parapharyngeal fossa, etc.? How does it reach there?
So it reaches to the stylomandibular tunnel of Patty, sir.
Yes. It's also a same Patty who described the fasciovenous plane of Patty.
Yes, sir.
It's like a dumbbell, it goes there and suddenly it causes enlargement. So that is one thing which you should know. Diagnosis is, why do you say parotid? Answer is clear. Why not parotid lymph nodes? Answer is clear.
Yes, sir.
They may ask you based on your consistency, can it be a lipoma? What are the other benign tumors which can occur in that area?
So lipoma, fibroma can occur.
Yes, only fibromas are not common. Okay. So lipoma is common. Yes, neurofibromas you can get. Nothing prevents in somebody getting it, but you have, these are the discussion which can take place in your patient. Okay.
Yes. Sir.
Any other questions from your side, or shall we go to the management?
No questions.
So what do you want to do for this patient?
So first I would like to do a ultrasound guided FNAC for this patient, sir.
No, first you say I will do ultrasound examination first.
Okay, sir.
First, always it should be ultrasound.
Ultrasound. Yes.
Why you want ultrasound?
To know whether it is first to know the exact location of the swelling, sir, and to know whether it is a solid or a cystic swelling, sir.
So anatomical location and anatomical part from which it arises from.
Yes, sir.
Good sonologist may be able to tell it is parotid or parotid lymph nodes or lipoma or neural tumors, or younger child means it can be a hemangioma, lymphangioma, etc.
Yes, sir.
So
Okay, sir.
location you would like to know. Yes, extent can be made out. Solid
Whether it is
areas and
solid-
cystic areas they can make out.
Yes, sir.
And then you can mention ultrasound guided FNS.
FNS. Okay, sir.
Why not to do a true cut biopsy?
So it will, if we do a true cut biopsy, it may breach the capsule and the tumor implantation may occur in the surrounding areas, which can lead to a recurrence.
Do you think the pleomorphic adenoma is a true capsule or a pseudo capsule?
It has a pseudo capsule, sir.
What do you mean by that?
It is not arising from the tumor per se, sir.
It's a compressed tissue itself with the fibrous stoma there, and with the
Yes, sir.
pseudopodia like branches are there which we can't see, microscopic. So if you put a wide bore needle, there is a high chances of a tumor seeding.
Tumor implantation. Yes, sir.
Ultrasound guided should be the answer word, but FNS is recommended. And let us say it comes as you are diagnosed only pleomorphic adenoma.
Yes, sir.
How do you proceed from here onwards?
So then we can do a CT, sir, to look for if there is any extra glandular spread, and if there is a
Do you suspect any? You can do CT scan. Nobody can tell you are wrong or right. You have to look at the economic concerns. If there any definite indication is there, you should do. What are the indications?
indications are if there is any skull base involvement, if there are any parapharyngeal spread to the tumor.
You have done a clinical examination. You said it's mobile.
Yes, sir.
It's mobile. Yes, of course, large tumor. You have a point there, but generally we don't have. This patient has not much of a neck, no neck nodes at all. Correct?
Yes, sir.
No bone infiltration.
No bone infiltration.
So it is a institutional policy. If you want, you can do it more than 10 centimeter size. Otherwise, clinically operable. No evidence of malignancy. FNAC you have done. You can straight away go for a surgical procedure.
Superficial. Yes, sir.
Yes. What is the role for MRI? Which is better, MRI or CT? MRI. What is the advantages?
MRI, it is helpful in delineating the normal gland and the tumor, sir, and we can also find out the perineural spread in a MRI, sir.
More importantly, the interface between the facial nerve and the tumor. Okay.
Okay. Yes, sir.
And you mentioned no skull base sometimes.
Yes, sir. Skull base.
Skull base infiltration, large neck nodes are present. So they may be along the jugular chain itself. You may have to do a radical neck dissection, modified radical, of course.
Modified. Yes.
In that situation, yes, MRI has an advantage. Just to see the bone, CT scan is better. There's a CT protocol you have to take, especially like everywhere now. Pancreas, yes. CT protocol. Every organ, there's a protocol. So
okay.
All operable cases like this, a mobile case, I do ultrasound guide FNAC. I will do the initial investigation to prepare the patient for surgery. Fitness is important, is 69. So cardiac status, yes. And followed by you go out for surgery, right? What surgery?
Yes, sir. Since there is only involvement of the superficial lobe, we can do a superficial parodidectomy, sir.
What do you understand by that term?
So, in case of a superficial parodidectomy, the superficial lobe, which is just anterior to the faciovenous plane of patty, is removed, sir, thereby preserving the facial nose.
So you have to say tumor along with all the normal parotid tissue which is anterior to the facial nerve. Okay.
Facial, yes, sir.
Not just the tumor, all the whatever compressed tissue or not compressed, anything which is superficial.
Okay, sir.
Otherwise, Otherwise, it causes
Injury to the
recurrence.
facial nerves. Recurrence. Yes.
Recurrence.
Okay,
One
sir.
of the more common problems of parotid, especially pleomorphic adenoma, is a recurrence.
Recurrence. Yes, sir.
What are the causes of recurrence in general?
Inadequate excision of the tumor, sir.
Say enucleation, better word. Okay, if you
Enucleate.
just
Yes, sir.
enucleate means you have left significant tissue.
Okay.
Yes. Next,
Uh,
we did mention about some investigation, ultrasound guided. What we should not do.
the FNAC, sir. The
True
sorry,
cut,
true cut
core
biopsy should not be
needle
done.
biopsy.
Yes, sir.
Starting from the core needle biopsy, operative may be an enucleation, inadequate excision, which you have mentioned,
Yes,
and more importantly, you should not breach the pseudocapsule. You know,
yes,
if you breach that pseudocapsule, spillage of the tumor cells can occur, and that is one of the important cause of a recurrence of the pleomorphic adenoma. Okay.
Yes,
So
yes,
this is the one important point to be kept in mind during surgery, right?
yes, sir.
Yes. Have you seen a case or seen a case of superficial parotidectomy? You have some idea, incision, etc., or
Yes, sir.
can you just quickly tell?
Yes, sir. We put a lazy S incision starting from the preauricular area, which that curves around the ear lobule and moves backwards to touch the mastoid process, and the incision is extended to the upper 1/3 of the anterior border of the sternocleidomastoid, sir.
So importantly, the incision to get an exposure to the, you have the lobe in front, behind, and below, right?
Yes, sir.
So you have
Yes,
to
sir.
take out that. That is why that exposure.
Yes.
Laziest because to avoid sharp
Avoid
corner,
sharp.
sharp
Yes, sir.
corner, because it causes
Injury to the mandibular nerve, sir.
no, that is different. Sharp corners will cause flap necrosis.
Flap necrosis. Okay.
See, the problem is whenever the flap necrosis is there, wound healing gets delayed, and the second infection, all the complications will set up.
Yes.
Same thing we do some kind of a lazy S type only incision in the inguinal region, correct?
Yes, sir.
For what condition you do the inguinal block dissection?
In case of carcinoma of the penis, sir.
Carcinoma penis you will do, or a melanomas of the lower limb. There also, you should not put a, there's an incision, there's a method in which you put so that flap necrosis infection happens means it's a major problem, especially neck dissection. If you are done, carotid vessel is exposed.
Yes,
like in the inguinal region, femoral vein is exposed. Blowouts can happen if there's
yes,
an infection. So that is one thing which we are always worried. Yes, one or two favorite questions. How do you identify the facial nerve?
The facial nerve can be identified by the Conley's pointer or the tragal pointer, sir. The facial nerve lies 1 centimeter deep and inferior to the bony cartilaginous junction of the external auditory canal. Or if we can find out the posterior belly of the digastric, the facial nerve lies just above the posterior belly of the digastric muscle, sir.
Where it is inserted to the mastoid, right? So,
yes, sir.
So you have it comes out of the stylomastoid foramen there. So
yes,
just above, you may be able to find out between the mastoid and tympanic plate. Okay.
Yes.
Yes, I think that's how the facial nerve recognition is the key issue in all parotidectomy. So
yes,
this is about superficial parotidectomy, means it is understood that it is done for benign condition and facial nerve is preserved. So that's what it is. When do you do total parotidectomy?
Total parotidectomy, if it is involving the deep lobe also, sir, but we preserve the facial nerves.
So what I meant, not the question of involving, even if there's a deep lobe tumor without superficial lobe, you have to remove superficial lobe also.
Yes.
I think if we forgot, this is also one of the indication for a CT scan. Okay.
Yes, sir.
you have any suspicion of a deep lobe enlargement, you can mention CT scan in the examination. We
Okay.
discussed that. I forgot to mention that moment. Identification of the facial nerve is the most important thing. I'm not sure whether to go into the depth of the surgical details at this juncture. What are the other things which you need to identify once you have identified the facial nerve? Next.
Sir, apart from that, we have to identify the greater auricular nerve, sir.
Okay, but not meant. What I wanted to answer is the branches.
Okay, sir.
Maybe a surgical technique, maybe a little too much. You take a right angle forceps and go on dissecting to find out the branches of the facial nerve. You have any idea what are the branches?
Yes, sir. The first, starting from above, it is the temporal branch, zygomatic branch, buccal branch, mandibular branch, and the cervical branch, sir.
So marginal mandibular and cervical.
Marginal. Yes,
so
sir.
you have to gently go on dissect between the tumor and the nerve. You have to keep close to the nerve so that your right angle force protect it. So that is why this is some kind of a messy surgery. When I say messy, perfect hemostasis is important here. Because if you miss the plane, you land up with the damage to the nerve and retromandibular vein also. What is retromandibular vein?
Sir, it is the maxillary vein and the superficial temporal vein together form the retromandibular vein, which passes through the substance of the gland, sir.
So that's a fasciovenous plane.
Yes, sir.
Right. So this is called as superficial parotidectomy. Total, when you say total lobectomy, also is facial nerve is preserved. So where you remove the both lobes, correct?
Yes.
Have you heard any term called as adequate parotidectomy? Adequate. Sometimes you get a tumors not exactly the location which your patient is got. I told you sometimes you get a small peripheral tumor. Okay, peripheral.
Yes. Yes, sir.
But it is in the parotid. Remember, if you look at the surgical anatomy, you find parotid quite in front. It extends almost 3 to 4 centimeters. So if there's a peripheral located small tumor, 2 centimeter, 1 centimeter or so, you don't have to really identify the facial nerve. You directly go over the swelling and you can move the tumor with 1 centimeter margin. So that is called adequate. So what is the advantage of adequate parotidectomy?
There is a decreased chance of facial nerve injury and recurrence.
Entire surgery on the parotid, the main problem is facial nerve. Main problem. So that's called as adequate parotidectomy. And also now new terminology is there, extracapsular
dissection. Yes.
So you can know about it. Technically little more challenging. When you probably do a post-graduation, you will understand these things better. What are the complications you can anticipate after say a conservative superficial parotidectomy?
Sir, first we can have a hemorrhage and then we can
you don't get a hemorrhage. There are don't expect hemorrhage to happen in a parotid tumor surgery. Surgeon has to be meticulous. We don't injure any major vessel set because the plane we are talking about the plane. No, if you go in the plane, we don't call hemorrhage. Yes, occasional blood may come from small vessels. It's not like a major superior third artery giving way or injuring the, let us say, jugular vein, etc. That will not be a problem there.
Okay.
What are the complications?
They could be a fistula, sir, or they can be Fraze syndrome.
Salivary fistula.
Salivary fistula.
Yes. Any other complication?
Fraze syndrome can occur.
Fraze syndrome. Also, what is the other name for that?
Gustatory sweating, sir.
So I think it's a mechanism. I think you people should know. Why do you get time is a little bit catching? So gustatory syndrome, mechanism behind it. What are the other complications?
There could be a fluid collection, sir. Seroma can occur.
Seroma. and
and
flap necrosis.
flap
I told
necrosis.
you, sometimes
Yes, sir. Flap
that is
necrosis.
actually a major issue.
Okay,
Secondary infection, and all these are the known complications which can happen. So
Okay, sir.
every attempt of this should be made to protect. Yes. When do you do radical parotidiectomy? What is the meaning of the word radical parotidiectomy?
Sir, we remove all of the tumor and also the remaining gland along with the facial nerve and the associated locoregional spread tissues are also removed, sir. It is usually done in cases of T3, T4 tumors, a carcinoma of the parotid, if there is any skull base involvement or positive lymph nodes or high-grade tumors.
High-grade tumors. So what are the indication to give a post-operative radiotherapy in all these patients? These high-grade tumors you mentioned, that is one of the things. Anything else?
Positive margins, sir. Close
Positive
positive
margins. Okay.
T3 tumors of the size T3, T4, sir.
Yes.
Positive neck nodes are present, sir.
Extracapsular spread, perineural image. Positive neck nodes, you do definitely do a selective neck dissection here, lateral neck dissection. So, but it's not a very radio sensitive tumor, but there are definitely, surgery is the best form of treatment for parotid tumors. So definite indication, larger tumors, perineural inversion, extracapsular spread, high grade. That's how you decide about that.
Yes.
Okay. Kishan, can I share some option is there for me? Kishan, you are there? I will try sharing, just see whether you can see.
Okay, sir.
Can you see?
Yes, sir. We can see your screens.
Yeah. I will just show you a few things like this is how you say that features to say parotid. Our Dr. Aakash, you have done a good job. Presentation is well. You deserve, you have become doctor. That's what he told me. So your presentation is fine.
Thank you, sir.
This is the typical features to say pleomorphic, monodular surface. Okay, that's what we say. Typically mentioned women, women and around 50. That's classical. But this is what is the surface anatomy. So parotid duct, where you have to feel, the line joining the middle of a line of between the lower body of the tragus and angle of the mouth. That's where the classical surface anatomy. I brought this from the internet only to show you there is another curtain sign related to spine. Okay, this is not related to carotid. You may get an MCQ in some questions. So those who are interested can go through it.
Thank you, sir.
See, I have brought these two pictures. I asked you a question that what condition. See, this is a classical. There's no doubt. This was a MS exam case in one of the, in fact, it is from a SVMC, that is a, but Sri Venkateswara Medical College, Tirupati actually, Tirupati.
Okay.
If you look at this, it's quite far away from the ear lobule, correct?
Yes, sir.
But it was a parotid. So it was a parotid. If you look, I'll show you the next slide to show you, see the extent of the parotid. See how much it can come. So even if the tumor arises somewhere here, it can grow like this. So always in and around the region of the ear lobule, behind the ear lobule, that's a mastoid region. Or even you may think the earlier case was, some people said lipoma, neurofibroma, etc., etc. But the consistency was firm. So it was a parotid tumor. So that's what is one of the questions they ask. Of course, PG level, they will ask you why not ear lobule raised.
Okay.
Yes, that's the simple picture. Now that's the curtain sign to know the upper border. Okay, upper
Yes, sir.
border. He's my very close friend, Professor, principal, ex-HOD of Tirupati, Venkateshwara Medical Professor Ramanaya. So he contributed that case. Now, lower border. I was telling you a case of a lower polar swelling. Okay.
Yes, sir.
One problem will come how to differentiate it from the lymph node. Here, angle,
Yes, sir.
deep cervical node. If this is a parotid, you can easily push it to the face over the angle of the mandible. If it is a lymph node, you cannot push it over the mandible. Clear or not clear?
Clear, sir.
Because lymph node is deep to the deep cervical fascia here.
Yes, sir.
So lower polar parotid tumor becomes more prominent when you put the sternomastoid into contraction.
Okay, sir.
Lymph node swelling in that area becomes less prominent when you put the sternomastoid into contraction.
Okay, sir.
Is it clear?
Yes, sir.
So if this, you can push it above means it is parotid. Is it clear? These are
Yes,
all
sir.
the for a smaller swellings. Yeah, this is of course classical smooth surface. Smooth. Now this is that nodular surface. This was irregular. So you should not only mention about the skin there, surface, borders, look at the shape of this. This was malignant mucoepidermal tumor.
Okay, sir.
Now look at this nodularity. Can you see this?
Yes, sir.
Very obvious, very obvious. This is a classical pleomorphic, mixed tumor. Now, this is again a, you see that zygomatic arch is here only, typical nodular. Now this, if you see such very large nodules, more than 1 to 2 centimeter, 2 centimeter, you can call him as bossulated surface. You get this kind of a picture sometimes in a Phyllodes tumor. You know Phyllodes tumor?
Yes, sir.
In the breast. So,
Breast. Yes, sir.
and look at this lady. She was a young patient with this kind of a picture in the parotid region. I have a small video of this. So I think it's obvious when you contracted the masseter, it was becoming more prominent, right?
Yes, sir.
So that's clear. Now, same patient, I am pressing it. So I'm not sure you saw that. The purpose of showing this is it was very soft, compressible swelling, young patient. Can you see some bluish thing like over the skin there? It's maybe
Yes, sir.
difficult. So this was actually a lymphangioma. It was transluminant. So soft swelling, very soft and compressible also. So yes, that's the place where you have to look for any deep lobe enlargement in addition to oral cavity, right? Behind the angle of the mandible.
Yes, sir.
Yes. What is your diagnosis in this patient? Look at that case. See the veins there. Can you see?
Yes. Yes, sir.
Very hard. This was a rapidly growing mucoepidermoid carcinoma. Very hard, right? You can see the veins there, dilated veins over the surface, right?
Yes, sir. Yes, sir.
See here. What is this fold here?
Platysma.
This is platysma sign. This
Yes,
was
sir.
a parotid tumor. See there behind it has gone large node also here, and platysma is pulled there. It's highly malignant tumor. So it was adenoid cystic carcinoma. That's of course picture of MRI, and this is for CT scan. So this was another case of a recurrent pleomorphic adenoma. These are the reasons, which we have, I think, already discussed.
Yes, sir.
Sometimes you remove and send it to pathology. They may miss a malignancy and they may report later. So missed malignancy, excision through the pseudocapsule, enucleation, all these can give rise to various causes of recurrence. Okay.
Yes, sir.
So just for the sake of everyone, this was the tumor. If you remove only this tumor means you will go through the pseudocapsule. So you have to take out the compressed tissue or a normal tissue all around. That's why the word superficial. Okay. So this was the
Yes,
tumor
sir.
along with the superficial entire lobe. That's called a superficial parotidectomy. Yeah, that's all from my side. If there is any questions which I can answer. Otherwise, Kishan. Any questions are there? Aakash,
No questions from my side.
Sir, it was a wonderful presentation and self-explanatory, hence no questions, I suppose. It was indeed a comprehensive clinical class. The discussion was very useful to us. Thank you so much, Professor Shenoy, sir, for
Thank you.
teaching and guiding us.
Thank you.
We are ever grateful to you. I need your blessings and support throughout.
Thank you. We'll
It
be
was a
always.
great effort by Dr. Aakash. We could learn a lot because of your well-prepared presentation. We also thank all the participants who were enthusiastically answering and were actively involved. Thank you, one and all. Have a great day.
Thank you. Thank you.
Thank you so much, sir. Thank you so much for patiently listening to my
Congrats,
presentation.
Aakash. Congrats.
Thank you so much, sir.
Okay.
Thank you, sir.
Okay. All the best to you.
Need your blessings always. Thank you.
Thank you.